beaucoup de gens ont congé le mercredi, mais voilà, on avait l'occasion d'avoir professeur Lyvonne TUME qui est en visite à Genève et puis qui venait voilà, nous voir, nous visiter aujourd'hui. C'était l'occasion de faire une conférence et puis même sur nos petits comités, ben on en profite, nous. Et puis, donc, professeur Lyvonne TUME est infirmière en pédiatrie, enfin en soins intensifs pédiatriques. Elle est australienne d'origine, de Brisbane. Donc, elle vient pas d'Australie exprès aujourd'hui pour nous, mais elle habite en Angleterre, près de Liverpool. Et puis, elle a une expérience de how many years? 10, 20?
30.
Yeah. Plus de 20 ans d'expérience en soins intensifs pédiatriques. Elle est professeure en soins intensifs pédiatriques. Et puis, son background est varié, mais surtout sur la nutrition. Et puis, elle va vous donner des exemples aujourd'hui. Et puis, elle est aussi la past president de ESMIC et a œuvré de manière très active dans la société. Et le WFPIX aussi, hein, the World Federation. Donc, on est très heureux de t'avoir, Lyvonne. Et puis, the floor is yours.
Bonjour, madame, monsieur. Je suis très heureux. J'ai doctoré ici aujourd'hui. Mais maintenant, je parle en anglais. D'accord? De la présentation en français. I hope that is okay, because as you hear, my French is not very good. So I'm going to talk to you today about pediatric nursing research, how it can shape and change practice. Well, how I think it can shape and change practice. And you are clinical nurses, and some of you are researchers, and hopefully it will be interesting. Oops. Yes. So this is Patricia Benner is a famous American nursing theorist you may have heard, and she said that the goal of nursing science is to make explicit the knowledge that is embedded in our practice, because often we don't do that. You know, we practice, we're very good at doing things, nurses are very good at doing things, but we don't actually study what we do very often, and we don't make it very clear what nursing adds. So when we talk about nursing science, you know, first of all, there's a process that we follow. And I know this might be slightly swayed towards quantitative research. And for that, I apologize. But first of all, I think we have to understand what do we already know about a subject, you know, and that is a systematic review of the literature, which can be qualitative, of course, doesn't have to be quantitative. And there's a lot more qualitative systematic reviews now in Cochrane. So first of all, find out what's out there. What do we already know about a particular topic? Then what do we think we do? That's an important thing. It's not an essential step, but I think it's really useful so that when you get results of your research, you can put them in the context of what actually happens, or at least what people say that they do. And this is quite useful. So often we use a survey, survey, to describe at least what practitioners think that they do or say that they do. And it's not perfect, but it's useful. It's useful to do. Then once you've done that, then it's useful to look at what you actually do, what we actually do in practice. Because what we say we do in a survey is not always the same as what actually happens in practice. We know that. And that you can do that in an observational study. And then once you've done that, you know what people say they do, you know what the literature says, and you know what's actually done. Then you can try and think about, can we study this? And I guess I'm heading towards a trial is what I'm thinking, but that's just how I think about this. So you can't just go straight into this. We always have to do some feasibility work, and it may involve a pilot study of for example, if you want to test an intervention to do something. And then once we've done the pilot study and shown that you can actually recruit these patients and there are enough of these patients, it's feasible to do the study, then we can go on to study it robustly in a trial. And I do believe that trials are important. but I also think that they should have often, not always, but often, an embedded qualitative study. We often call that a process evaluation, so that when you get the result of the trial, you can explain that. Because if you don't get the result you found in a trial, then sometimes it's quite difficult to explain why if you don't do some qualitative work. So what about historical practices? Particularly, so my background is, as Anne-Sylvie said, is pediatric ICU, reanimation pédiatrique, and there are lots of historical practices that we do as nurses, and in pediatrics as well. Oh, sorry, I'm trying to do two things here. So we often, and I don't know if you do, you can ask yourself whether you do this in the PICU or the NICU or the wards in pediatrics. Do you still use gastric residual, residual gastrique to guide enteral feeding? Long. Even European guidelines are 4 hours for formula milk for children, and 3 hours for breast milk. But still, if you look at your practice, that might be what your guideline says that you do, but in reality, we looked at this recently, it's much more than that. So these are problematic, and they're problematic for the child and the family as well, of course. Heparinized saline, if you work with solutions like an arterial line or central line. In the UK, about half the units use heparin in their saline. This is a drug. It comes at a cost, quite significant cost, actually, compared to using normal saline, 0.9%. And there isn't much, well, there's no evidence really, limited evidence in pediatrics that one is better than the other, but one is extremely costly. So this is stuff that we do I know we don't always prescribe it, but, we put this up every day and change these lines every single day. Even the amount of fluids that we give children, we have this historical formula that we use, you all know it off the top of your head, in 1957. So this formula we use, Halliday Sager, we use it and then we almost ignore it and we apply 80% restrictions, 70%, 60%, 50%, or if you're very unlucky and you're a cardiac child, 40%. So, we don't even know, if it's not right, then why are we still using it? We use it and then we do something else. So there is some basic stuff that we do in pediatrics. We don't even know what is the optimal feeding formula. There are loads of feed formulas out there. The companies will tell you, this one's fantastic, this is what you should use. Inevitably, it's more expensive. But actually, we don't know which is the better one to try and improve feeding tolerance in children and critically ill children. And even different suctioning techniques. In specific groups of children, we have some evidence, but they're not all the same. In a PICU, particularly in a pediatric ICU, there's a huge range of children with different pathology. In neonatal intensive care, it's more homogeneous, I know that, but still different groups. So this is why I asked the question, is the intensive care unit an evidence-free zone? And there is, if you haven't seen this, in intensive care medicine in April this year, there was a famous intensivist, professor of intensive care medicine, adult intensive care in London, Mervyn Singer, and he wrote this free-to-access editorial, or review he called it, but really looking at intensive care in particular and the evidence being either non-existent, weak or outdated, and then we often overinterpret and misapply the evidence. And, he really encourages people to reappraise your current practices, not, how should we put them onto ECMO and all this sort of stuff that people love to do. And I work in an ECMO center, but, actually the stuff that we do, the day-to-day stuff, often lacks a lot of evidence. So what else? If there isn't evidence there, what ends up happening is you've got historical practices happening. And I've just put a few examples up here. There's practices around this gastric residual volume measurement in the UK, where we do this all the time, and it really probably stops feeding. They also do it in neonatal intensive care, and we looked at decision making, and it's really not based on any evidence. Other things around, as I said, fasting for extubation. So extubation is the common thing that you're going, every child who's in the ICU intubated is going to undergo at least once. So every, morning or sometimes at midnight, depending on how your unit works, we fast these children. And, you can see that across Europe, this was, it was an international survey, actually, it wasn't just across Europe, huge range of things. And again, these children aren't fed proper meals. It's not like they have to fast a long time, because most of them aren't getting very much. But we're still fasting them way longer than we should. This is another study looking at, this is in neonatal intensive care, same problem. Also using gastric residuals, less than in pediatric ICU, but still used a lot. And the colour being quite important in the neonatal ICU, trying to, think whether you can diagnose NIC earlier, but that hasn't been shown to be the case. And all it does is restrict the baby achieving their full feeds. This is an interesting study where they looked at staff attitudes toward when they would treat fever in the ICU, pediatric ICU. So they asked the junior nurse, the more senior nurse, a junior doctor and a senior doctor, at what point would you, for the clinical practice in green, when would you treat the fever? You can see the more junior the nurse, the lower the threshold to treat the fever, but it was quite varied, whereas the more senior person, less so. And for a trial, what would they accept? If we were to do a trial of permissive temperature targets, what would they accept? And again, varying amounts of practice. So these are basic things. These are day-to-day things that we do all the time. Treating a fever. This is the prescription for paracetamol is written up usually as required. And so really it's down to the nurse to decide, if it's not for pain, when would you give this? Oops, next slide, trying to do both. And this is what I said to you about fluid, maintenance fluids. So not volume, not resuscitation fluids. This is just the amount of fluids you need if you put the child on a drip. And we did this survey across Europe, and this is just one of the practices again. So you can see the variation. We asked them about children in a general pediatric ward, also children with renal failure, those on a ventilator, after heart surgery, etc. And you've got fairly extreme differences between what people would restrict it to. So this is using the Holiday Sager formula as the standard, which everyone does. And then how much would they use? Less than, more than. There's a big range, even amongst the same patient groups. So again, this is a practice that needs investigating, I think. So how, when we need, as nurses, we need to also generate evidence for safe and more effective care for our children. This is one of our children in the ICU who was after heart surgery, had their chest open. You can see the chest is open, and a common patient for us, but actually a lot of what we do in this child, nursing care, as well as some of the medical care, that lacks really an evidence base. So this was another interesting paper in intensive care medicine a number of years ago now by a colleague of mine, Mark Peters, who's a professor of pediatric intensive care medicine in London. And he said these are the clinical uncertainties facing the intensivist. Well, I would say these are also the clinical uncertainties facing the children's intensive care nurse. We have all similar, not exactly the same questions, but very similar questions around how do we best sedate these children? How do we assess sedation and actively do stuff to target sedation? Because we do some things, but we don't do the whole lot. How do we best deliver, in our case, inotropes and reduce hemodynamic compromise when you change them over? What about extended monitoring? How useful is near-infrared spectroscopy, for example? Ventilation, assessing weaning and extubation readiness, fluids feeding, all these things. I think the one thing he forgot, because of course he's a doctor, is that there is other people involved in the child. Should be a child, that's a very big child, grande enfant. They of course forgot the parents, yeah? in the pediatric and the neonatal ICU, it's not just the child, is it? We work with the family unit, and they're equally important. And of course, he didn't mention that, but there's also questions around how best we can support the parents and the family to deal with this admission at the time and afterwards. And so really, as nursing research, which isn't everyone, I know, but we need to develop a scientific basis for the care that we deliver to these children and their family, because that's, we need to show what is optimal care, what's safe, what's effective, and a lot of that we still don't know. So this is a quote from, I couldn't find the actual quote because it's years old, but I really think this is true still now. Nurses are the ones that we deliver 85% of the care in intensive care, hands-on care delivered by nurses. Yet if you look at the research in the field, most of it's undertaken by physicians. And I think we need to change that. We need to ask ourselves why, and we need to change that, because they're never going to ask the questions that make a difference often to nursing care and what we do. They focus on different things, which is fine. But then, there's a whole lot of nursing care that's just not addressed, and we lack an evidence base for. So there are a number of hazards or, adverse events that can happen just because you're in an ICU, and how do the nurse is really key in trying to prevent some of these hazards. And there was a quote from the Royal College of Nursing in the UK, and it's old now, but it was looking at nurse staffing, and it says, patients are helped by the timely reduction of sedation, weaning from ventilation, rehabilitation, and psychological support that's provided by nurses. And also a lot of our care is proactive. We try and decide, this patient, I don't feel this is not going well. Things are going to happen. This is, they're going to have a cardiac arrest or something bad's going to happen here. And trying to prevent this from happening, and then providing skilled care in the event of sudden deterioration. And this requires a skilled clinical nurse, and of course, experience is important as well. But so is education. And so how can we reduce the risks? Well, we can assess the risks properly using valid tools. We can intervene to reduce the risks and try and promote early recovery. And we can evaluate the impact of our interventions, and we should do. So first of all, sorry about the extra bullet point there. First of all, this is just some study from mine many years ago, PhD work actually. But first of all, we actually don't know. Sometimes we haven't even described what the risks are. People think there's a particular risk. When I started my PhD in 2006, I worked in the pediatric ICU, but I had worked a lot with head trauma patients, traumatic brain injury. And all the nurses always said to you when you started doing this, I remember this for 20 years, just don't touch the child, because whatever you do, it's going to put the pressure, the intracranial pressure up, put the pressure inside the head up. So it's everything we do. So just don't touch them. And I thought, is it everything we do? Because there's loads of things that we do. And I tell you what we do them all at once. Suction them, we turn them, we clean the eyes, clean the mouth, and then, so how would you know what it is? Is it everything? I just didn't think that was the case, but no one had broken them down and described, well, what is it? Is it all of them? And what is the effect? Because unless you know the effect, how do you know how to do anything about it? So first of all, we did this. And of course, what we found is that there were two of the interventions, suctioning and log rolling. LR is log rolling, so cervical spine thing. So they were the two things that really made a significant change in the intracranial pressure, both during and also at 5 minutes after. The other three things, washing, cleaning the eyes, no impact. So it wasn't those things, actually. So again, unless you describe it, you think you know what happens, but often we don't know what happens. So try and put this all up. So basically, there was a number of papers around that, but what I concluded is, if you think about traumatic brain injury, probably it's likely to, although I didn't test this, but if you combine the two interventions that cause the most rise in ICP together, suction and log rolling in these children, that's unlikely to be helpful, because we know that if you This is a study done quite a large number of patients, including children. You know, and what we know is that traumatic brain injury, it's this cumulative intracranial pressure burden over time. So if you have it sustained up, and you can see the data is 8 minutes in children, then worse outcomes. And what we found is there was, you know, because they did them together, log roll and suction, if they did that together, they were sustained for quite a long time, sometimes 40 minutes. So it would be useful, and what we changed our guidelines to make them done separately. So the others you can do whenever you want, but lug roll and suction were separate. So we would always plan to suction them now about 40 minutes to an hour before you plan to turn them, because if you try and turn them and you haven't suctioned them, then we all know that you will need to suction them. So, but you know, again, unless you study that, you don't know that. And it's not a complex thing. It was a very simple thing, you know? Then once you've done that, this is a different study, but again, just saying, described what the impact of stuff is, and then try and test interventions to see if the risk can be reduced. Is one method of suctioning safer than another? So there are two methods that we all use. Your unit may have a preference for one. Our unit at the time had a preference for, we used open suction, and still a number of the ICUs do use open suction. And so as we used both, we decided we would compare one another in a randomized controlled trial, in a crossover trial of very high-risk cardiac babies after 48 hours after cardiac surgery. High risk, high event rate in these children, cardiac arrest rate was 18%. So they're, you know, high risk, single ventricle patients. And what we found, so we had the randomized control trial, and then concurrently we did an observational study where we asked the nurses to collect their own observational data, because they did suctions outside the trial. And interestingly, they nearly all chose open suction, 70%, because that's what they preferred, because that was the norm. Although they could use closed suction because it was in. And actually what we found was that was you know, if they used closed suction, the risk reduction was 47% and the absolute risk reduction was 32% using closed suction. I mean, that, you know, so whatever people preferred, it didn't correlate with outcomes. And actually, when you look at it and test it properly, so we changed to closed suction. So now the unit uses closed suction. That's the default for every patient, but specifically these patients. And then in top of testing interventions, which I think is really important, these are nursing interventions. These are things that we as nurses do. The other thing we need to understand is sometimes the effects of some of the devices we use. This is interesting. So this is she was visiting PhD student from Sao Paulo in Brazil. She works with Mavilde, Professor Pedera. They've got a fantastic nursing laboratory there. One of the only ones in the world where they do a lot of stuff around IV therapy. And anyway, so her PhD was looking at the effect of 4 different infusion pumps you use to deliver blood cells, you know, red blood cells to children. And so they had three pumps that they commonly used in Brazil. We do know the names of them, but we didn't publish that in the paper. One had a particular cassette mechanism. So I don't know if do you know what I mean? But it was like an infusion pump. I don't know what brands you use here, but you open the door and you put this cassette in and then you run it through that way. And the other 2 were syringe drivers, but different brands. And what she found is that and of course the nurses could choose to use any of the 3. They were all available in this hospital. But actually one of them caused significantly more damage to the red cells and potassium release and other things than the other 2. And so, you know, this is important to know this, because this is a nursing decision which pump you use often, unless you've got all one pump and you can't choose. But in many hospitals, there's a choice. And also there's a choice in terms of, you know, lobbying the hospital to get a different pump if this one is not right. So I think it's important there's lots of things that nurses can do. And, you know, other people probably won't study these things because they don't do these things. So what about getting evidence, research evidence into practice, into clinical practice? This is an ongoing problem in my unit, and I suspect in yours as well. So this is a quote, and it's true though. It's a very important quote. Doing research is no use unless it gets to the people who need to use it. So the nurses at the bedside, the doctors at the bedside, the physios at the bedside, unless it gets to those people who can change practice, then why are we spending 200 million, 2 million Swiss francs, for example? And actually, there was some work done in the American Journal of Nursing years ago now, but they said, so I think this is true. They said that many nurses still didn't value research, clinical nurses, and they didn't have little training to understand them how to find evidence and on what to base their practice. So historically, if you've got, depending on when nursing education changed in Switzerland, a lot of nurses who were old, who trained many years ago, didn't get this information, weren't taught about this in their education program. Hopefully it's changing. I would like to say it's changing in the UK, but I don't think it is. But that's a problem. Well, yeah, slowly, yeah, but not, at least just slowly. So, I mean, this is a study that was one of my PhD students did, Laura Rad, and she looked at, she did an international survey, but it wasn't, I'll explain, it wasn't exactly a survey, it was more than that. And she looked at endotracheal suctioning by nurses. So what she did was, and as I said, this is a nursing, we do this, right? No one else much does this. There are some best practice guidelines on, but some of these aren't really evidence-based. They say they're lacking in evidence or based on adult literature or preterms, whatever. So what she asked the nurses to do in this survey was, and she went through many countries. There were about 15 countries involved. The survey was translated into 15 languages. So what she asked them to do was, on a particular 48 hours, whenever they suctioned a child on the unit, after they'd done that suction, they logged on and completed one of these surveys. So the survey was supposed to relate to what they'd just done, the procedure. So it's not just a what do I do, because of course it relates to the child. How you suction a child with bronchiolitis might be different. Well, it will be different to how you suction a 15-year-old patient with a head trauma. So what she found, and we defined, 4 components of evidence-based practice, which you could argue is not perfect, but we had to get a definition. And in terms of our definition, only just around a quarter of nurses internationally, and there were a huge number of responses to this survey, I might add, I should have put that in. They didn't, there was only a quarter of them that met the criteria for evidence-based practice, meaning the most common procedure that we probably do in the ICU, in PICU or NICU, is not evidence-based or being performed in an evidence-based way on many occasions. There were nurses that were saying they were still suctioning every 2 hours, etc., etc. So, yeah. So what about evidence-based practice in nursing? It's the gold standard. We know it should be done, but actually we know that as little as 20% of interventions actually reach patients that have an evidence-based. There are a number of barriers and facilitators, but one of the big things are time constraints, having the time. Lack of role models, I think, is really important to guide staff in evidence-based practice. Organisational culture, there's a habitual adherence to how we've always done it. We've always done it this way at Alder Hey. We've always done it this way in your hospital. This is how we've always done it. And that's not helpful attitude, I suppose. And poor leadership as well, poor clinical leadership. And many nurses still don't understand or have the skills to practice evidence-based, to look for evidence and to question things. And this was the strongest predictor for whether you practiced evidence-based, was whether you knew, understood it, and had the skills. But I still think the biggest challenge that we have is to change healthcare professionals' behaviour. All of us, not just nurses, everyone. I'll give you an example in a minute. And so this is a famous phrase, and we see this. So I'll give you an example in a minute after I've told you about this. So how, I've struggled for, 5 years really now to try and think, how can we improve this? Well, you can try and develop and implement local guidelines, and people do. But the problem is, unless the people developing these guidelines understand evidence-based practice and look at the evidence, then they're not always evidence-based. They're often written to be like you do. Does that make sense? They're written so that they reinforce what you already do. That's a common thing. So they can be evidence-based, but they're not always. Journal clubs. Well, we run journal clubs, and I can tell you, no nurses turn up because they're at the bedside, right? But who I get is a bunch of doctors, which is fine, but you know, it's a problem. It's a real problem for us. And then if nurses do an academic course, so they like a CPD course, you know, like an intensive care certificate, or a master's, obviously you're forced to engage, but you know, but that's a forced thing in a way. I think roles, clinical academic nursing roles, having well, the US called it a nurse scientist. I probably call myself that as well. They're helpful, having them on site in the hospital. I mean, it's all very well. I sit in the university and I do go to the hospital a day a week, but you know, at the university, that's fine, but that's not going to help really implementation into practice, because I go into practice and then I see it's not being done, you know? And so a couple of years ago, we started some evidence-based rounds. That's what we call them. And that's a picture of one. I'll explain these. Oops. Which apparently is called visited here, not a round. So what we did, and I don't think this is a perfect model, but I think it would have to evolve. But I went to the bedside. We took about an hour every week. And we chose, you know, there were 20 patients in this ICU. So we didn't do all 20 patients and nurses, but depending on the situation at the time on the day, we discussed with the nurse in charge, okay, we might go to this patient, this nurse, whatever. We had a clinical librarian. These people, they're very rare, actually, but this hospital in Bristol had a clinical librarian. And so she came out of the library and she took notes. And so we asked the questions, well, what is the evidence base for, I don't know, using saline with suction, for example? But there wasn't a lot of examples. So she would write this down and she would go away and do the searches, because that's her job. That's what she does. She would go away and do the searches and then send this back to all of us in a PDF form. These were all the papers I found around this. So if you want to write something or do and then there's some staff that didn't always read the emails, whatever, or didn't see it. So we had a copy placed in the staff room as well. We didn't ever ask the parents to leave during these rounds. Some of them did. Some of them just sat there. And some of them, you know, occasionally you had parents that were really engaged. It was one of the mothers who had a chronically ill child, and she was a pharmacist. But she hadn't worked for 3 years because of her child. And she said to me, this is fantastic. I used to teach evidence-based practice. Can I get involved? And we said, of course you can, you know. So she was really engaged. And she said, you know, well, I've got a question for you. She said, in another ICU that this child was in, my child was in, and he'd been in a lot, they used to have this quiet time in the afternoon, 2 till 4. And the lights went out, everything, you know, we didn't do anything. We just had this quiet time. But you don't have this here. Why not? What is the evidence for this? Great question. Yeah. So, you know, we didn't ask. As I say, most of them weren't that engaged, but you got the odd parent who was. And you know, it generally went well. I left this hospital at the time. We did some evaluation, and the nurses who went said it was useful. But again, whether it translates to long-term effects, we need to see. I think we have to think of different ways that we can try and do this. I think I'm not a joint clinical academic role, I should say. I do a day a week in practice, but I'm not funded by the hospital, so they don't pay for me yet. So the university, you know, I go and I'm allowed to go a little bit. But, you know, ideally, some people have a 50-50 or something, and they're funded by both institutions. And there's they're called clinical academic roles for nurses. And there's lots of papers coming out now about how some of the evidence or some of the effectiveness of these roles and what they can achieve, and particular models. Now, medicine has had this for years. You know, professors of medicine, they all work in the ICU, right? They don't sit at a university, but sometimes they do, okay? So it's well established in other fields. It's just not established in nursing and also other allied health, physiotherapy, you know, dietetic. But this has to change, I think, because this is one way. And I think it's a key way to try and actually get evidence into practice. And this is meant to be, you know, if you do clinical research as a nurse, that, you know, other researchers have a laboratory, yeah, you know, test tubes, etc. But, you know, for us as a nurse researcher, our laboratory is the PICU or the NICU or the, yeah, that's our patients, that's our laboratory. You just have to explain this to people who are scientific or, you know, science-based or, you know, because they think it's separate, but it's not separate. It's what we do. And then, oh, sorry about that. So how else can we get evidence into practice? Well, guidelines, they definitely help. Clinical guideline papers, they help clinicians implement things because clinicians are time poor. You're busy, right? You're on these 12-hour shifts. We all know, we've all done them. And, you know, you're not going to go, unless you have time that's away from the bedside, you haven't got time to do this yourself. So if a group have done this, looked at the evidence and reviewed it and produced recommendations, this is easy because you can just pick it off the shelf and implement it. So it's supposed to be easy. And they do help. But alone, they're not enough because someone has to do it, put it into practice. And that, in a big unit, that is often challenging, or in any unit. So we started writing after these guidelines came out. The last set we did, and another set's just been accepted in ICM, is that we started to write these implementation papers, not published in high-impact journals, but just to try and help clinicians put these things into practice. And so we used a model, we used Pronovost, but there's loads of models to implement things into practice now. But you've got to make it easy for clinicians to do this because they haven't got the time and they probably haven't got the skill that you've got. So you need to also change people's attitude and the mindset, we would call it. So here's an example. Oops, sorry. Here is an example of a recent journal club that we had. So I think really what we have at the moment, certainly in my unit, and you can tell me in yours, we have experience-based medicine or healthcare in the ICU, i.e. this is what I've done, this works for me, and we don't have evidence-based medicine, I don't think. So we had a journal club recently, and there were 2 papers that recently came out about the use of high-flow nasal cannula compared to CPAP. They're 2 separate trials, 2 separate papers published in JAMA, High Impact Journal. One was step up, so prior to intubation, and one was step down after extubation, which was, they were both non-inferiority, so trying not to show that they were better, but that high flow was no worse. Because of course it's easier to deliver, it can be delivered on the wards, the child needs less sedation, etc. So that's what we found. So the step-up study, if you haven't read them, they're open access in JAMA, found that CPAP, high flow was non-inferior to CPAP. So it wasn't unacceptably worse. I know it's hard to understand. It's hard to explain as well. But you've got benefits, okay? And step down found it was not non-inferior. That means, or the implication is that CPAP was more effective after you come off the ventilator, post-extubation. So anyway, this journal club was presented, a doctor presented one of the nurse practitioners presented one, and then we said to the group, well, how will your practice change? And they said, both very senior, they said, wow, I prefer to start them on CPAP. I think it's more effective. And the other one said, well, clinically, my experience is they do better on high flow. So, you know, and my question to you and to my colleagues and to me is, why are we spending all this money? Millions of Swiss francs, pounds, dollars, if we're not going to change practice. So this is, for me, this is where we're at now. The problem is there's increasing number of trials, but we're not putting it into practice or selectively putting it into practice. If it agrees with what we already do, then it's easy. What else? I think we also need to identify and investigate important PICU problems. So what are the problems that are important for the service, for the patients, for the parents, not just We have a phrase in English, navel gazing. What's the equivalent? And Sylvie, you know, like what do nurses think about nursing patients on ECMO? Who cares? I don't care what they think about nursing patients on ECMO. Does that make sense? Because it's not going to benefit the patient. It's not going to benefit the parents. It's not going to benefit the service. You know, I don't know if you're asking. So they do. You know, we need to study things that make a difference. Is what I'm trying to say. And so for that, there's a lot of these done. Research prioritization exercises. So we did one in the UK in 2019. We've just redone that actually 5 years later. It was 2018 we did it. We did healthcare professionals first, and then we did parents, and we compared the two. So I just put the top 6 up there, but they're not the same. Parents' priorities aren't the same as ours. They were not hugely dissimilar, but you can see the ranking was a little bit different, the mean score there. So, you know, but these at least are generated by a group of people and parents. And James Lind Alliance is a UK thing. So we get funding for about £40,000, and they do a proper partnership with the parents, and that was done recently with nutrition. So again, it's not just then me saying, oh, well, I really think that it's important to study, feed formula Y or whatever, because actually there's some things that we need to, these are the problems that have been identified as being important, and that's what we really should focus on if we want to make a difference to the service, to the patients, to the families, to pediatric ICU. So my take-home messages, I put that à la maison. Nurses we need to question the evidence for our practices, and particularly these historical or, you know, ancienne pratique, because we have a lot of them. I'm sure you can think of lots. We need to generate the evidence for our practice, we need to be scientific and systematic in our approach to doing this and do research well, not badly. Multi-professional research is the future. I don't believe nurses work alone. They don't. But that's not to say that we, nurses, can't lead study teams. We do. I do. And Sylvie does. Chantel, yeah, we do. You can lead them, but it's not going to be all nurses. It's going to be doctors, dietitians, whatever. But you can lead them. And getting research evidence embedded into practice is probably one of our biggest challenges now for the next 5 to 10 years, because we can keep putting out these trials, large trials, 8,000, 10,000 children, but they're not doing it. But I do believe that ultimately pediatric nursing research, whether it's intensive care or otherwise, can shape and change practice. And hopefully I've convinced you of that. And I hope some of you are coming to the winter school, ethnic research school. That's it.
In Lausanne.
In Lausanne, yeah, no less. Oh, sorry. It is, yeah. Sorry, just there we go. 2 things. Yes, please. Okay, question. But you have to speak very slowly if you speak in French. Very slowly. Do you see any?
I have one. If nobody has one. Okay, so you go first.
Yeah.
It's a little curiosity about the academic, clinical academic roles. Because recently I saw a couple of people from UK basically that have that roles. I want to know more about the role in the clinical base, because I know that academic, I want to know the other way, how it works and what exactly are your duties there.
There's very few people in these roles. One of our colleagues, Joseph Manning, who you know, is the only one in pediatric intensive care in actually one of those roles where he's funded half and half. So their role clinical depends on what area they work in. So if you're talking about intensive care, well, what he does, we have these critical care outreach teams. So they see patients after discharge to the ward. And also if they trigger an early warning score, they will go and see these patients on the ward. So he is a charge nurse with the outreach team. So he's been in that role for a number of years, I think, before this, and he's just carried on being a clinical, in that role. But I mean, others, if you talk to other people, the clinical aspect of their role is really different depending on, you know, some in adult intensive care, for example, and in the UK, they get a lot more money for some reason. But, you know, many of them, they have these follow-up clinics, you know, sometimes funded. So some of the hospitals, not all of them. And often you'll find that the clinical academic nurses are involved in the follow-up clinics, you know. So, but it really varies. There is no standard clinical practice because everyone's clinical practice area is different, you know. So when I do my clinical, I mean, because I'm not funded at the moment to do it, but I do it. I just go into the ICU as a senior nurse. So we've seen whatever, you know, sister, we call in Navy, you know, these terms are old fashioned. I'm not in charge. I don't do in charge, but I just, we have like a runner, you know, what's the equivalent? So you don't get allocated a specific patient, but you're sort of spare. Yeah, so if there was someone that came in, cardiac arrest or something, you would. Yeah, like a float. Yeah, float, yeah, that's right. Yeah. So I do that, and then it means that you can go and speak to the nurses and patients, and, you know, where it's busy, you can help, and I just do that.
Basically, float bedside.
Well, around all the bedsides, yeah. So we have a unit that's 24 beds, 8 different pods. I work in the cardiac ICU. It's my preference, yeah. Yeah.
Can you hear me?
Yes, I can.
That's okay. My question is more about the implementation.
Yeah.
Do you have one priority from the management to improve this implementation in practice?
No, I don't have one.
Yeah, experience.
No, I don't have one thing. That's the problem. I think there's loads of things that can help, and I think you have to approach from lots of different angles. I think journal clubs help, but the nurses can't come. If they can come, that's great. Having, you know, guidelines that are evidence-based, but someone has to write them. Yeah. These evidence-based ward rounds, they help. I think they help. And they make it seem, you know, so the clinical academic nurse would lead them, I suppose. I think they're helpful, and they fit into daily practice. So, you know, we choose the time that suits, and we choose the patients that suit, and, you know. Yeah. 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 I do it, yeah. I did it in Bristol. I worked in a city for a couple of years, and they had this clinical librarian. So when I moved back to Liverpool, we don't have a clinical librarian. They're very rare. So it doesn't work the same way. In fact, they've got no librarian at all at the moment, but they will get one. But, you know, this is a new role, because what I don't want to have to do is, so I can't go and do all the searches for them, you know, because that was her role. So all we do is I just try and discuss common things and ask them, you know, do they know the evidence base for this? You know, why are we putting EMLA or Amatop on 4 lines? Do we, you know, what is the evidence for that? Only because that was a challenging systematic review that indicated that it was no better than placebo. So just to try and challenge them, that some of the things that they think are true are really based on no evidence at all. You know, I mean, we take out chest drains every day and we don't even know the best way to do that. There's no evidence on that in children at all. And this is a daily occurrence. You know, even the best analgesia for chest drain removal, which is quite a painful procedure. There's just so many things, you know, and then, yeah, once you start getting them to think about, well, you know, why are we doing this? Why are we suctioning this way? Why have we put heparin in our bags? You know,
from the management, there is,
yeah,
maybe more specific points.
Well, I think I'd ask them to come. So I always ask the nurse managers to come. So I say to them, you don't have to say anything, because they say, oh, I don't know, I'm going to feel stupid, I'll look stupid in front of my, I said, don't say anything then. Just don't have to say anything. You just, I'll talk and we can, so, and I bring anyone. We have medical students. If they're there, I drag them over as well. And also nursing students, anyone. I just take anyone now. Because actually it's all about thinking about this together as a collective group. But getting the managers on board is key. It's good, so invite them. If they can't come, they can't come, but they feel invited, and then maybe some days they will come. Because I think often the managers are senior nurses and they didn't have the training on research and evidence-based practice. They feel they haven't got those skills. And so that makes it worse. So they don't want to feel stupid, and I don't want them to feel stupid, because that's not going to help. So, yeah, it's a challenge, a big challenge, I think. So, yeah. Any other questions?
What would be your top 2 advice, or 3, to motivate and engage nursing managers and decision makers to increase the number of master prepared nurses, advanced roles, and also roles to develop nursing research in a hospital?
Yeah, I mean, it's a question. In the UK, nurses have to pay for their master's degree, and it's £2,500 a year. So most of them can't pay this or won't pay this, and I understand that. The nursing salary in the UK is not very high. So, and they get no time. So first of all, I think, if you want nurses particularly to do masters and PhDs, you need to fund some of that. You need to give them some time, and you need to fund the fees. So that's step 1. And that often doesn't happen. Sometimes it does. We might be lucky to get 1 a year. And that's where it starts, really. Support and funding for them. But again, you've got to engage with the managers if they don't value it themselves, research, I mean, and, how are you going to convince them? So we've got a plan. We haven't done it yet. We've got a plan to meet with, I've got a plan to meet with all the senior nurse managers in the hospital, right from the chief nurse down, to find out what their top 3 priorities are. What do they think are problems that we need to be looking at, researching? So my view is that once we get a list of these, do some sort of prioritization exercise effectively, then I'll say to them, right, these are the top 5 priorities that you, as the managers of this hospital, have decided are important. So let's part fund a PhD or a master's degree to look at this topic. The university works with you part. So this is a topic that you've just said you want done. You've said it's important to the hospital now. And if you fund the master's degree and give them some time, then it will be done. The main reason that nurses, particularly nurses, drop out of PhDs and masters in the UK is no time and no funding. Whereas the ones who are funded and have time nearly always complete. So again, it's working with the managers. I think you've got to get them on board. This is, you said, not me, you said this was an important topic for this hospital to look at now. You said all this. So let's fund some studies, or people do the studies in these areas. I don't know. I'll let you know whether it works. But it's really hard to engage with them, because if they don't value it and don't see it as important, it's very hard to get past that, isn't it? But we've just got to keep chipping away. That's my view.
Do you have a lot of, actually, we have 2 minutes left, then we have to move on.
Good.
Do you have a lot of research-trained nurses in the middle management?
No, none, 0. And in fact, when you look at, it's not just our hospital. I looked in the city, the city of Liverpool, it's got about 8 or 9 hospitals in the city. And I looked up every chief nurse, they're the person in charge of that hospital. So I looked them up, I Googled them, and to find out what qualifications they had. 2 out of 10 have a master's degree. So, and one of them doesn't have a degree. So she's quite old and trained and hasn't gone back and even got a degree. So I think that tells you a lot, doesn't it? Yeah. So
I think that's probably one of the strategies we have to do.
Yeah, absolutely.
Because when I was back in Perth, the CEO of the Children's Hospital was a nurse with a PhD. And nursing research, there was an institute of nursing research and several nurse researchers working on the floors, and so it makes a big difference. Yeah. So,
and I've worked in hospitals. If that person is engaged and has, as you said, like a PhD, they will make that happen in their hospital.
Ok. Donc, si vous avez d'autres questions avant qu'on ferme, merci d'être venu. Merci Lyvonne.
Merci.
Yes, that was really good. Thank you. Ok, donc bonne fin de journée, semaine.
Are you going to IUFRS? Good to see you.
Je peux voir avec ça.
Merci.